your presentation. You are Dr. Ahmed from Mansoura University, Egypt, talking about volumetric overload shocks and the patho-etiology of transurethral resection, prostatectomy syndrome, and acute dilution hyponatremia. So, hello.
Thank you very much indeed.
Thank you.
Yesterday, I presented the physics proof that Starling law is wrong. Today, I'm outlining the clinical significance of that. Well, can we have the first slide, please?
Yeah, sure. 1 minute.
I'd like to thank Mr. Chairman, ladies and gentlemen. I'd like to start by thanking the people who helped me to be here today. I thank the organizer of this webinar and my co-author and daughter Salma Ghanem for making my attendance possible. Next slide, please. The title of the presentation today, Volumetric Overload Shock in the Patho-etiology of the transurethral prostatectomy syndrome, and why is Starling law is wrong based on the hydrodynamic of the porous orifice tube. Please, next slide. The authors are Salma Ghanem and myself, Ahmed Ghanem. Next slide, please. The last 32 years of my career life were spent in investigating and reporting these articles. The articles recognize two new types of shocks and its treatment. It proves Starling law is wrong and provide alternative mechanism, the hydrodynamic of a porous orifice G-tube. Next slide, please. These discoveries resolve the puzzles of three clinical syndromes, discovering its patho-etiology and new successful treatments, namely the transurethral section known as the TURP syndrome, acute dilutional hyponatremia, the adult respiratory distress syndrome. Two new types of vascular shocks are volumetric overload shocks, recognized and defined here. Next slide, please. The two clinical studies aiming to understand the TURP syndrome and recognizing VOS were done. A prospective clinical study on 100 consecutive TURP patients, of whom the condition of the TURP syndrome affected 10 patients with severe hypotension shock and bradycardia and severe acute dilutional hyponatremia of less than 120 millimole per liter, presenting with coma next morning to physicians. Volumetric overload was the only significant factor in causing the condition, as shown in the next slide, figure 1. This shows the volumetric overload in these patients. The first, the mean and the standard deviation. The first mark is the glycine absorbed, which is about 2 liters. The IV infused 5% dextrose is less than a liter. Saline-based fluid is about 1.5 liters during the operation, and the total sodium free was 2.5 liters. The total volumetric overload during 1 hour procedure was 3.5 liters. Next slide, please. The second clinical study involved a case series of 23 cases of the TURP syndrome manifesting as VOS1. Volumetric overload quantity and type is shown in figure 2. The first 3 cases died as they were diagnosed and treated erroneously as one of the recognized shocks and treated with further volume expansion. The remaining 20 patients were correctly diagnosed as VOS1 with coma and treated with hypertonic sodium therapy of 5% sodium chloride and or 8.4% sodium bicarbonate. Each patient passed 4 to 5 liters of urine, followed by recovery from shock and coma. This treatment was successful in curing all patients, bringing them back literally from the dead. Next slide, please. The volumetric overload in was one of the TURP syndrome. These groups of patients, the first group 1, were 3 patients who were misdiagnosed as another shock and treated with volume expansion. They gained 10% of their body weight of fluid given during the therapy. The second group of the patient were those treated with hypertonic sodium solution, and they gain total of 7% of their body weight fluid, which is about 5 liter during 1 hour surgery again, and they were successfully treated and recovered. The 3.1 and the 3.2 groups were those 10 patients occurring in our prospective study, and randomized into 2 types of treatment. The first group, 3.1, were treated with hypertonic sodium. The second were treated by fluid restriction, avoiding excessive volumetric overload. One of the 5 patients in the conservative group developed coma with convulsion and paralysis diagnosed by the neurologist as a cerebrovascular accident, but he was successfully treated with hypertonic sodium. The conservative treated group had morbidities, which I shall talk about in a minute, but those who treated with hypertonic sodium all recovered completely. Next slide, please. Definition: the transurethral resection of the prostate syndrome, known as the TURP syndrome, is a severe vascular hypotension reaction that complicates endoscopic surgery as a result of massive irrigating fluid absorption, causing severe acute dilution hyponatremia of less than 120 millimole per liter, manifesting with shock during the surgery, but by next morning it manifests with coma, convulsion, and paralysis. Next slide, please. Volumetric overload shock, or VOS, is a condition caused by massive fluid gain and is of 2 types. Type 1 VOS 1 and type 2 VOS 2. VOS 1 is induced by sodium-free fluid gain such as 1.5% glycine, which is used as irrigating fluid during endoscopic surgery, and or 5% glucose. It is known as the TURP syndrome or hyponatremic shock, as hyponatremia is a marked serological marker for the condition. Next slide, please. VOS2 is induced by massive infusion of sodium-based fluids of crystalloid and colloids, such as normal saline, Ringer, Hartmann, plasma substitutes, and or blood transfusion that may complicate the therapy of VOS1. VOS2 may also complicate fluid therapy in the acutely ill patients suffering from other known shocks, such as hypovolemic, hemorrhagic, and septicemic shocks. VOS2 presented with the multiple dysfunction syndrome, or known as the acute respiratory distress syndrome, ARDS. Both VOS1 and VOS2 are complications of fluid therapy in hospitals. Why should the TURP syndrome recognized as VOS? VOS1 is the real patho-etiology of the TURP syndrome, which has hyponatremia as a clear serological marker. It has been induced in animals under clean experimental conditions in the absence of hemorrhage and sepsis. Recognizing VOS1 makes it easier to recognize VOS2, which is otherwise very difficult to recognize. It helps establishing the correct life-saving therapy of hypertonic sodium of 5% sodium chloride or 8.4% sodium bicarbonate. Finally, it disproves the Starling law of the capillary interstitial fluid transfer. Next slide, please. During the operation, the TURP syndrome presented as vascular hypotension shock to the anesthetist and the urologist that is mistaken for one of the recognized shocks. By next day after surgery, it presented as encephalopathic hyponatremic coma to physicians. Next slide, please. The TURP syndrome was first reported by Creevy in 1947. as acute water intoxication when distilled water was used as the irrigating fluid. Water intoxication caused intravascular red cell hemolysis and acute renal failure. Then shift to osmotic solution was made and 1.5% glycine was used. Harrison et al. Reported the TURP syndrome as acute dilutional hyponatremic shock after massive gain of glycine irrigating fluid. However, the TURP syndrome is not limited to the TURP surgery. Next slide, please. It may affect any endoscopic surgery. It affects women undergoing cervical endometrial resection. It may also affect women undergoing any prolonged major surgery following excessive 5% glucose infusions. The TURP syndrome manifests as shock during surgery, and by next morning, it manifests as hyponatremic encephalopathy, coma. The TURP syndrome may be mistaken for other recognized shocks, such as the septicemic, hemorrhagic, and cardiogenic shock. Next slide, please. Those two may complicate all types of shocks during fluid therapy, and the transition is seamless and hard to detect. It may be called the irreversible shock. The only way to detect those two is the sudden acute increase in body weight, more than 10%, or by keeping accurate fluid balance during fluid resuscitation. The serum solute changes of VOS1, particularly hyponatremia, has been reported by all authors on the TURP syndrome. Next slide, please. The TURP syndrome may present as hyponatremic encephalopathy, coma, cardiogenic shock, cardiac arrest, respiratory failure, or arrest, and acute renal failure, among other vital organs involved. Visual loss has been reported in both eyes. Post-mortem examination has been documented. The TURP syndrome has been attributed to glycine and ammonia toxicity, but it has also been reported with mannitol and glucose, which have neither ammonia nor glycine. Professor Han from Sweden reported 480 articles, of which 340 articles were in the TURP syndrome, according to PubMed search in December 2016, investigating the fluid and electrolytic dynamics, effect of overhydration on cardiac muscle and other organs, effect on renal function, and compared glycine to mannitol. Professor Han favored the toxicity of glycine as the patho-etiological cause of the TURP syndrome. He has contributed many missing pieces of the puzzle of the TURP syndrome. Next slide, please. Ghanem and Ward introduced the concept of volumetric overload in the patho-etiology of the TURP syndrome in 1990. Ghanem confirmed the effectiveness of hypertonic sodium 5% sodium chloride and or 4.4% sodium bicarbonate. He also investigated the underlying faulty physiological law of Starling for the capillary interstitial fluid transfer. Next slide, please. The etiology, VOS1 is induced by the absorption of 3.5 to 5 liters of glycine irrigating fluid through the periprostatic veins during the TURP surgery. Intravenous infusion of 5% dextrose augments this effect. It is important to realize the significance of time, as 3.5 liters of fluid may be considered as the normal daily fluid intake, harmless if gained over 24 hours or several hours, but it is certainly pathological when gained over 1 hour. In VOS1, 1 liter of sodium-free fluid causes a drop in serum sodium concentration of 7 millimole per liter. Next slide, please. VOS2 is induced by the gain of 12 to 14 liters of sodium-based fluid reported in ARDS causing this. The volumetric overload in surviving patient of ARDS ranges between 3 and 10 liters. The problem here is that every hypotension is considered synonymous with the hypovolemia and is treated with massive volume expansion. In the past, VOS1 was wrongly attributed to one of the known shocks and treated with sodium-based fluids, inducing VOS2. Next slide, please. The occurrence of massive interstitial tissue edema with congestion of the vital organs, pleural and peritoneal effusions in the presence of severe hypotension shock was the reason to cast doubt on Starling's law. Shock is a disturbance at the capillary cellular level impairing the capillary interstitial fluid transfer, delivery of oxygen, and removal of waste products. Next slide, please. This process and edema formation are governed by Starling law. In this law, the arterial pressure is considered the force causing capillary filtration. If this is true, how come that arterial hypertension, though very common, never causes edema? Starling based his hypothesis on Boisil's work on a straight uniform brass tube. Next slide, please. Later evidence, however, demonstrated the capillary is a porous, narrow orifice tube as it has pre-capillary sphincter and pores that allow the passage of plasma albumin and proteins that were discovered in 1967, 80 years after Starling reported his hypothesis. Because the capillary pores allow the passage of plasma protein, hence there is no oncotic pressure force at all in vivo. A call for reconsideration of Starling hypothesis was previously made. The alternative to Starling hypothesis was found later in 1984. Next slide, please. The hydrodynamic of the G-tube is totally different from Boisil's tube, as I demonstrated yesterday. The proximal arterial pressure induces a net negative side pressure gradient on the wall of the G-tube, causing inflow suction, which causes absorption, most prominent over the proximal half, and turns gradually positive higher near the distal half, causing filtration. The incorporating the G-tube in a chamber C, representing the interstitial fluid surrounding a capillary, demonstrated a rapid dynamic magnetic field-like fluid circulation between the surrounding chamber and the G-tube lumen, as I show in a figure in a monument. Incorporating the G-tube and the surrounding chamber in a circulatory model driven by electric pump inducing proximal pressure similar to the arterial pressure in human circulatory system caused suction from the surrounding chamber into the lumen of the G-tube. Next slide, please. The net pressure in the surrounding chamber is negative. The pressure also in the interstitial fluid space and under our skin subcutaneous is also negative of -7 centimeter water as measured by Guyton and Coleman. Distal venous pressure is responsible for augmenting filtration. This proves that the circulatory system is not an all-positive pressure system. The arterial pressure causes suction, not filtration, at the capillary interstitial fluid transfer, and hence Starling law is wrong. The GC circulatory magnetic field-like phenomenon is autonomous, having both filtration and absorption forces, making it a true replacement for Starling's law. Next slide, please. The clinical picture of VOS1 has the following clinical picture before it transfers into VOS2, with a full-blown picture of multiple organ dysfunction syndrome known as the ARDS, characterizing both conditions. It is noted that VOS1 presented during surgery as hypotension shock and the next day as hyponatremic coma. When the TURP surgery is done under general anesthetic, cardiovascular signs and respiratory cyanosis appear first. When done under spinal or epidural anesthesia, cerebronervous symptoms of clouding of consciousness appear first. This is a summary of the clinical picture of volumetric overload shocks presenting as multiple organ dysfunction syndrome known as ARDS. We have cerebrovascular system involvement, cardiovascular system involvement, respiratory system, as well as other system happening as well. The main feature or most serious feature of the cerebral nervous system is coma, convulsion, and paralysis. The main feature of cardiovascular system is shock and bradycardia. Cardiac arrest may occur. Cardiovascular shock is prevailing. The main respiratory feature is acute lung injury or pulmonary edema, and later ARDS. The other system involvement are renal, acute kidney injury, hepatic system is involved with dysfunction, gastrointestinal tract has paralytic ileus, general trunk edema or anasarca does occur. Then we have coagulopathy, bleeding at the operative site, and leukocytosis in the absence of sepsis. The therapy of the condition, as soon as the diagnosis of VOS is made, further isotonic fluid infusion is contraindicated. VOS 1 is treated with hypertonic sodium solution in the form of 5% sodium chloride, and if not available, 8.4% sodium bicarbonate is equally effective and available in every resuscitation trolley. This is given in a fractionated doses of 200 ml over 10 minutes through a central venous line under clinical and biochemical monitoring. The dose may be repeated up to 5 times with maximum of 1 liter that is required. The effect of this therapy is truly magical. Next slide, please. The result of the treatment, we see the cardiovascular shock is corrected and elevation of arterial pressure occur. The kidneys respond with massive diuresis that should not be replaced. The patient recovered from coma. The treatment has proved equally effective in VOS 2 that complicates VOS 1, particularly when given early before vital organ congestion develops into area of necrosis and infarctions and before MODS becomes failure. Next slide, please. The supportive measures these are achieved on intensive care units are most helpful. If the kidneys do not respond by diuresis, try hemodialysis setting the net fluid balance to negative. Both VOS 1 and VOS 2 were induced in animals and treated successfully with hypertonic 5% sodium chloride. This is to remind you of what I presented yesterday, that in an orifice tube, that the side pressure is negative over the proximal part, as demonstrated by sucking red fluid into the manometer tube. Next slide, please. This is to complete the negative pressure gradient around a porous orifice G tube. The negative suction occur at the proximal part is not shown here, but it turns gradually positive to become maximum positive towards the exit. And then we have the surrounding magnetic field like circulation. If you look closely here, you will find that this water around the G tube moves in a magnetic field shape, filtration from the distal end and absorption from the proximal end. Next slide, please. The G tube causes a net negative pressure in a chamber around it, as demonstrated by the caving in of a membranous chamber around the G tube rather than ballooning out. Next slide, please. Another way of demonstrating the negative pressure of the chamber around the G tube is connecting it to manometer, which sucks fluid from a jar 300 millimeter below the level of the G tube. Next slide, please. This figure demonstrates the GC circulation, showing that the circulation of the fluid in the surrounding chamber move in an opposite direction to the flow inside the G tube and the circulatory system. Injecting air moves towards the proximal end. It is showing moving in a series of photographs of 4. I stopped the injection. It started to move, and then it clears out very fast after stopping the injection. Next slide, please. This is another diagram like I presented yesterday, demonstrating the magnetic field-like fluid circulation between fluid inside the G-tube and that in the surrounding chamber. The proximal pressure BB here pushes the fluid through the orifice, creating a fluid jet inside the G-tube that comes out against distal pressure, and this creates a net negative pressure around the G-tube, causing suction at the proximal part and filtration at the distal part, creating a magnetic field-like fluid circulation around the G-tube with a net negative pressure in the chamber around the G-tube. Next slide, please. This is the GC apparatus enclosed in a circulatory model driven by an electric pump at the bottom here, with manometer measuring the proximal pressure, which is above 75 millimeter here, and the distal pressure is about 7 centimeter behind the blue plastic tube. Both manometer inside the chamber around the G-tube has a negative value lower near the inlet and slightly higher than at the exit, and both of them are lower than the distal pressure. Next slide, please. The TUR presented with VOS1 and volumetric overload represented the real patho-etiology. Previous authors have advanced glycine toxicity as the etiology, and shock was mistaken for one of the recognized shocks. The massive interstitial tissue edema affects all tissues and vital organs, but sign of one organ may predominate. In conclusion, that you are recognizing that TURP syndrome as VOS1 with its hyponatremia as marker helps to recognize those two which are otherwise unrecognizable. The correct and living therapy for VOS1 and VOS2 is hypertonic 5% sodium chloride or 8.4% sodium bicarbonate as prescribed previously. It is important to correct the faulty underlying Starling's law and advance the new mechanism for the capillary interstitial fluid transfer based on the hydrodynamic of the porous orifice G-tube. Next slide, please. The autonomous rapid dynamic magnetic field-like fluid circulation between the chamber around the G-tube and the G-tube lumen is self-sufficient to explain the capillary interstitial fluid exchange and replaces Starling law in every tissue and organ of the body. Next slide, please. I am certain that when the concepts presented here become fully appreciated, recognized, and comprehended, it will help to save thousands of patients' lives suffering from multiple organ dysfunction syndrome or acute respiratory distress syndrome that are affected every year all over the world. Thank you very much for listening.
Thank you, Dr. Ahmed, for your presentation. Any question?